Welcome to Biomicroscopy of the lids. This video course will introduce you to the examination of alterations at the lids. In order to achieve this goal, the first chapter on topographical landmarks will show you how to find your way in the microanatomy of the lids. And the second chapter, entitled Analysis of Details, will draw your attention to minute details which are relevant for the windscreen wiper function of the lids.
How to find your way within the microanatomy of the lids. In the anatomical field, 4 elements are examined with the slit lamp: the mucocutaneous surface epithelium, the lashes, the glands, and the inner edge.
The field is subdivided according to either a surgical classification or a clinical classification.
The borderlines of the fields in both surgical and clinical classification differ.
When surgery is the point of interest, the lids are subdivided into a muscular portion and a tarsal portion. For surgical purposes, then, the border is the gray line external to the tarsal glands.
For the clinical evaluation of the relationship between lids and globe, it is the surface of the lid margins which is the main target of interest, and thus a different subdivision is used: the differentiation between the cutaneous part and the conjunctival part. For this differentiation, the separating border lies internal to the tarsal glands.
The mucocutaneous surface consists of a part made of skin epithelium and a part made of conjunctival epithelium.
The cutaneous part is the part that is dry, and this part is covered by keratinized epithelium. It contains other elements of skin tissue: the lashes and their accessory glands, that is, sweat and sebaceous glands, and the sebaceous tarsal glands.
The conjunctival part is the part that is wet, and this part is covered by smooth mucous epithelium. This conjunctival rim is an extension of the conjunctiva across the inner edge, so that conjunctival epithelium forms a small strip along the inner lid margin.
One of the important topographical landmarks is the border between cutaneous epithelium and conjunctival epithelium, that is, the border between dry and wet. Actually, the position of this border determines whether wet or dry tissue comes in direct contact with the globe.
This mucocutaneous border can be made visible in specular reflection. For this purpose, either the lid margin is shifted until the reflex at the tissue surface appears, or the incidence of the light beam, that is, the angle of illumination, is varied until the specular reflex can be made out. The specular reflex of the dry cutaneous epithelium appears rugged, and as the irregular surface offers reflection angles at an immense number of points, the specular reflexes can be seen over a wide area.
In contrast, the wet reflex of the conjunctival epithelium is smooth, and since the reflecting surface is flat, reflexes occur only at a small range of angles, and thus are seen only in a very small area. This is why the wet reflex at the marginal rim appears merely as a narrow strip. Thus, in practice, looking for the delineation of the rugged reflex is the means by which the border between the cutaneous and the conjunctival part of the lid margin can be made out.
In a normal lid, this border is just behind the orifices of the tarsal glands. Between mucocutaneous border and inner edge, a rim of wet conjunctival epithelium remains, as shown by the strip of wet reflection.
Note: the correct diagnosis of the mucocutaneous border may be jeopardized by conspicuous changes in the subepithelial layer. For example, here, where a change in color along the margin seems to indicate the border. But actually, this color change, as revealed by the examination in specular reflection, does not correspond to the delineation of the rugged reflex.
A border is found also when we examine the distribution of the vessels in the subepithelial tissue. An abnormal aspect may be related to either an increased visibility of the vessels, which is mostly a sign of atrophy of the skin, or to an inflammatory or circulatory hyperemia, or to a combination of both.
Normally, the vascular border is the end of the network of the superficial conjunctival capillaries, which, in the lower lid, form an irregular network, and which, in the upper lid, are arranged in parallel lines. As a slight variation, the end of the capillary network at the vascular border may be marked by a delimitating capillary arcade. At the cutaneous part of the lid margin, the large vessels are usually barely visible because they are buried under the hazy cutaneous epithelium.
In old age, however, as for example in the case here, the large vessels in the cutaneous part may become visible and may run even across the border. Sometimes capillary neoformations are formed between the two networks right at the edge of the lid margin.
In inflammatory hyperemia, both types of vessels may become dilated, so that the dilated cutaneous vessels merge with dilated conjunctival capillaries.
In more severe cases of lid margin inflammation, we find a generalized transformation of the vessels, so that the distinct separation between the vascular networks of conjunctiva and skin at the border is abolished. Compare this with the normal case we saw before.
The hyperemia at the lid margin may be restricted to the conjunctival rim only, if the inflammation is confined to the conjunctiva.
Other topographical landmarks are the lashes and their accessory glands. Abnormal positions are either due to a dislocation of the entire row, or to single ectopes, or to a transformation of tarsal glands into cilia-bearing glands. This distinction is clinically important because for each variation the therapeutical approach is different.
In the normal lid, the accessory sebaceous glands at the ciliary roots can be seen through the covering layers and be recognized by their yellowish tinge. In indirect illumination, the outlines of the sebaceous glands can be made out in more detail. After the light beam has been placed just at the right-hand side of the target, the gland is observed on the left of the illuminated area. If both the ciliary and the tarsal sebaceous glands produce a well-visible sheen, they form two bright yellowish bands at the lid margin. These increase the contrast against the tissue in between, so that the gray line, as seen here in lower magnification, becomes very conspicuous.
Dislocated cilia are clinically relevant if they reach the inner edge. Here, the inward displacement of cilia has been caused by a dislocation of the entire ciliary row. Compare this with the normal position here, and here again, the dislocated row. The displacement has been caused by this contracting conjunctival scar.
Here we find just a few ectopic cilia, whereas the regular ciliary row has remained in its normal position.
And in this case of ocular pemphigoid, we see a transformation of tarsal glands into cilia-bearing glands. The abnormal cilia emerge at the inner edge along a red strip of conjunctival tissue, while the normal lashes are in their normal position.
The next topographical landmarks are the orifices of the tarsal glands, which appear as dots at regular intervals. The position of these orifices determines where the secreted sebum will be active.
Usually, the orifices stand in a single row. But ectopic glands may occur. These may be single ectopies, such as this single gland, seen here beside the slit light, which stands closer to the inner edge than the other glands. Or there may be multiple ectopies forming a double row. These are seen here very distinctly owing to a slight inflammatory reaction at the orifices.
The clinically important topographical landmark is the inner edge of the lid margin. It is straight in its longitudinal contour and is rectangular in its transsectional contour. Any change in its position or its shape impairs the windscreen wiper function of the lids.
The transsectional contour is best evaluated in the narrow slit beam because the optical section gives precise information as to the position as well as to the shape of the lid edge. The correct apposition of the inner edge of the lid to the globe is shown by the narrow slit light being continuous over the lid margin and the globe, while in cases of insufficient apposition, the slit light is interrupted at the meeting point of lid margin and globe. The interruption of the optical section is a means to allow the diagnosis of even slight imperfections.
If the insufficient apposition has been caused by a faulty position of the lid, as in this case of ectropion, the inner edge remains rectangular, as shown in the optical section with the narrow slit light.
If, on the other hand, the faulty apposition has been caused by a change of contour of the inner edge, the narrow slit light reveals a round contour instead of a right-angled contour.
Anomalies at the lateral canthus may impair complete lid closure. Unfortunately, they are easily overlooked, as in all other aspects the lids may appear normal.
The angle at the lateral end of the lid is acute in the normal eye.
Here, the angle is obtuse. Thus, lid closure has been incomplete during sleep. Note how the lid margins look normal. In this particular case, the obtuse angle is the result of a congenital anomaly, where a small block of dermoid-like tissue is interposed between the upper and lower lid margins. Its structure is quite different from the surrounding tissue, with a lipovascular and a fibrous part, and optical section showing its contour to be quite prominent.
In this second case, the obtuse angle at the lateral canthus has been caused by shrinkage of the lid skin, and the resulting incomplete lid closure has induced corneal damage as shown by this scar.
Slit lamp examination of the lacrimal punctum can help in the diagnosis of obstructions at the orifice proper or in the downstream pathways.
The normal punctum is situated within the conjunctival part of the lid margin and thus surrounded by conjunctival epithelium. The orifice is lined by translucent epithelium with a sharp delineation, both internally and externally. The lumen appears dark in direct illumination due to the shadow cast into it, whereas in lateral indirect illumination, it appears bright due to light propagation from the illuminated surrounding area. In optical section, patency of the orifice is shown by an interruption of the narrow slit light.
In this case of occlusion of the punctum itself seems to be normal at first glance. But on closer scrutiny, we find the epithelial lining hazy, as if covered by a veil. Furthermore, we see tiny capillaries running across the punctum. And in optical section, the obstructing conjunctival epithelium can be seen directly, as an intact layer.
In contrast, in this case of an occluded lumen, the bright ring of the epithelial lining is well delineated. This indicates the punctum to be intact and the obstruction to be in the deeper parts of the outflow system. And this is easily proven by pressure with a cotton tip on the nasal end of the lid and the ensuing extrusion of pus.
In this chapter, we will discuss microsigns of wrong tissue at the wrong place. We will analyze tissue alterations at the inner edge, pathological deposits at the lashes, tiny changes of the cutaneous epithelium, and pathology of the orifices of the tarsal glands. Tissue transformations affecting the inner edge may bring pathological particles and secretions in contact with the tear film and the globe.
Major tissue transformations, such as the sequelae of a chemical injury, are easy to diagnose. The mechanical impact of the sharp-edged exuberant keratinization as a cause of severe damage to the globe is evident. But in many cases, the tissue transformations causing discomfort are subtle.
To demonstrate an example, let us go back to the first case shown in this program. When the lid is seen from the outside, we notice only the abnormal direction of the lashes which point upwards. Compare this with the position of the lashes in a normal lid. When the lid is everted, we hardly see any changes at first glance. The conjunctival vessels show no irritation, and through the transparent conjunctiva, we can recognize some enlarged acini of tarsal glands.
But when we compare this lid margin with a normal one, we notice it to consist of cicatricial tissue, and the typical features of a normal lid margin are missing. The conjunctival vessels show the characteristics of the large vessels in the orbital conjunctiva, whereas the capillaries normally present at the lid margin are lacking. There are no orifices of tarsal glands, and what we see at the lid margin is debris of keratinized epithelium.
Compare this with a normal lid margin.
The conjunctival rim at the edge is missing, and the cutaneous epithelium reaches up to the very edge, which signifies that it may be in direct contact with the tear film.
Basically, most of the septal alterations of the lid edge are related to a shift of the mucocutaneous border, either inwards or outwards.
In this case of cicatricial conjunctivitis, the cutaneous epithelium has been drawn over the edge and now extends towards the inner side of the lid, so that the dry reflex also appears on the inner side of the lid. Here we see even a wide band of macerated keratinized epithelium, which desquamates into the lacrimal film and so becomes a source of chronic irritation.
On the other hand, the border may be dislocated outwards, as in this case of cicatricial conjunctivitis. The wet reflex can be seen extending to the outside, and the dry reflexes end external to the lashes. As a result, the mucocutaneous border has been shifted in the opposite direction, that is, towards the skin, and the orifices of the tarsal glands are facing towards the conjunctiva. Thus, the sebaceous material is secreted directly into the conjunctival sac. If we examine the surface reflexes at the orifices, we recognize protuberances, which indicate that the secretions are densified and solidified. This assumption is substantiated here by the presence of extruded, elongated solid material. All these surface irregularities may cause irritation. But the main culprit for symptoms is the solidified extrusion from this gland here, because this has caused a chronic surface abrasion of the cornea.
Secretory and inflammatory materials around the lashes are signs of various diseases. The detection of their origin is essential for a proper therapeutical approach.
The secretions may derive from either a local source at the ciliary roots, in which case they are signs of a disease of the ciliary glands proper,
or the material may come from distant sources and just be trapped in the grid of the lashes. In such a case, the site of origin of the secretions may be the conjunctiva, the tarsal glands, or a generalized skin disease.
While the search for the source of the secretions is easy in case of a highly active acute disease, it may become difficult in case of low activity at the site of origin.
In acute inflammations, usually the material of the secretions is purulent. For example, here the source is a purulent infection of the conjunctiva and cornea, and the origin from the conjunctival sac is evident.
In this next case, on the other hand, the purulent inflammation is localized at the lid skin and surrounds a cilium. When the cilium is removed, we recognize that the inflammation has also affected the ciliary root, because the bulb of the cilium has been destroyed.
Just compare this with the root of a normal cilium.
In chronic conditions, the site of origin is more difficult to assess because the secretions may cover the cilia as well as the skin surrounding them. We have to look for other signs, such as, here, the associated deformations of cilia roots, to identify the origin of the disease at the ciliary glands.
In the next case, we see the major part of the lid margin to be clean, and the secretions to be confined only to a narrow area. This points to a local disease. And indeed, in the area concerned, we find an inflamed tarsal gland. This is the source of the secretions which have just been trapped in the ciliary row. There is no reason to suspect any disease of the ciliary glands themselves.
Here, on the other hand, the secretory material is dispersed along the basis of all cilia, so that their origin is difficult to assess.
In this particular case, however, the secretions are confined only to the posterior row of the cilia, whereas the anterior row has remained free, and thus we may deduce that the actual source is not in the ciliary glands, but in the conjunctiva.
If we analyze the nature of secretions in chronic conditions, we may distinguish between homogeneous liquid oily or semi-fluid material, which indicates a continuous hypersecretion, and non-homogeneous material, which indicates secretion either in an irregular sequence or intermingled with material of different consistencies.
If the secretions are oily fluid, their surface reflex is smooth, and in indirect illumination they are transparent. At the surface of the epithelium, they are just lubricants, but otherwise they leave no visible traces.
Semi-fluid secretions are less transparent, but they are also homogeneous in structure, and thus have an even surface too. Where they cover the skin at the basis of a cilium, they have a regular cyclical or polycyclical boundary. Note the fine strip produced by refraction phenomena in indirect lateral illumination, revealing an otherwise invisible boundary. When drying, secretions of semi-fluid material surrounding the shaft of a single cilium may form scales that are homogeneous in structure and thus semi-transparent. and when engulfing several cilia, they form accumulations with even and reflecting surfaces.
In contrast, non-homogeneous material is crumbly in structure. When dry, its surface is irregular. It may fracture, and thus crusts on the skin may have irregular polygonal outlines. Any otherwise invisible margins can be made out by refraction phenomena in indirect lateral illumination. When dry, non-homogeneous secretions surrounding the shaft of a cilium form whitish-yellowish crumbs with irregular surfaces.
Conditions affecting the cutaneous part are related to either atrophy or hypertrophy of the skin tissue.
Pathology of the cutaneous part may impair the function of the various glands at the lid margin and thus affect the lubrication of the eye. Important changes involving both the epithelial and the subepithelial layer are easy to recognize, such as those due to chronic exposure, in this case of inveterated ectropion here.
The detection of alterations confined to the epithelium alone, however, requires a judicious use of the special illumination techniques. In this case of hypertrophic epithelium and beginning papillary transformation, the optical section shows the thickened epithelium between the narrow light slit at the surface and the slit at the underlying tissue.
The increase in thickness of the epithelium can also be revealed by observing the crest of the lid in retroillumination against the background of the globe. Then the thickened epithelium appears as a translucent strip on top of the edge of the lid, which is bright against a dark background and is dark against a bright background. Furthermore, in this case, the tissue transformation has caused fine striations. These can be revealed by the examination of specular reflexes, which show a pattern differing from the normal rugged epithelial reflex.
But keep in mind that striations are not always the result of tissue transformation. They may be merely plications due to tractional artifacts, which are always directed towards the finger retracting the lid, and thus may occur obliquely, depending on the direction of traction.
Now, in case of striations due to a real transformation of the epithelium, the fine plications occurring in the thickened layer can be revealed not only by their reflexes, but also in indirect lateral illumination, as fine refracting striations on the left-hand side of the light slit, that is, on the side opposite to the incident light. Another proof of increased thickness is the small strip of light-scattering tissue covering the background on the right-hand side of the light slit. The recognition of increased light scattering can be enhanced by using the red-free green filter. This filter renders the scattered light from the covering epithelium more conspicuous and thus increases the haze covering the cutaneous part.
When we evaluate the tarsal glands, the main clinical criterion is the patency of their orifices.
The orifices of the tarsal glands appear as a row of dots, with a small lumen filled with bright secretions in the center, a darker surrounding rim of epithelial lining, a more or less distinct brighter halo of the tissue surrounding the epithelial lining.
And here, the corresponding wet specular reflexes, showing, by their width, the extension of the secretions into the surroundings.
In contrast, an occlusion of the orifice can be suspected when there is no wet reflex and the rugged dry reflex has extended over the orifice. This indicates that keratinized epithelium has covered the area of the orifice. The excretory ducts of the glands may remain visible in direct light beneath the epithelial cover despite the occlusion.
In this particular case, however, the ducts do not appear in direct light, but the hidden ducts can be made out in indirect illumination, and then are seen as bright spots in the dark field beside the illuminated area.
In this next case, with marked epithelial thickening, the excretory ducts have been elongated. The ducts appearing glassy in lateral indirect illumination have no connections with the outside, as demonstrated by the specular reflexes which are not interrupted and thus show no signs of open orifices.
In this case, with an inflammatory transformation of subepithelial tissue and vessels, the orifice and excretory duct have disappeared, and only calcified remnants indicate the original position of the occluded glands.
In the next case, the gland still functions. The secretions push the epithelial cover forward, and thus we see a blister. There is a similar protrusion in the immediate vicinity, but this looks different. Whereas on the occluded gland on the left, the reflex is rugged, which indicates epithelium. On the protuberance on the right, the reflex is wet, indicating liquid. And indeed, when the lid is touched by a cotton tip, the drop of liquid can be wiped off, while the blister with its epithelial cover has remained intact. This epithelial cover requires a sharp instrument for removal and for giving the secretion access to the exterior.
Another occluding factor may be the secretions themselves, which are easily visible if protruding, as here, where they have formed a peak when drying.
In this case, however, the occluding secretions form flat scales on the surface, and thus are difficult to recognize. Only by lateral indirect illumination can their margins be made out clearly.
Based on the normal pattern of the anatomical landmarks and the normal structure of the tissue, the tumor was considered as benign. This hypothesis was confirmed by biopsy. The diagnosis was a blue nevus. With this analysis of a tumor suspected of malignancy, we close the chapter on biomicroscopy of the lids.
Welcome to the biomicroscopy of the tarsal conjunctiva, a means for the diagnosis of external diseases. This program will show how the examination of the conjunctiva at the tarsus and especially at the upper tarsus is an efficient means for the evaluation of external diseases of the eye. This program contains 2 parts: topographical landmarks and analysis of details.
Topographical landmarks. For clinical purposes, we distinguish 4 areas: the tarsal conjunctiva, the orbital conjunctiva, the bulbar conjunctiva, and the limbal conjunctiva. This program is confined to the tarsal conjunctiva.
Tarsal conjunctiva. The conjunctiva of the upper tarsus has a typical aspect due to the regular pattern of the vessels and the tarsal glands. Even slight disturbances are easily made out, and this is the reason why the examination of the tarsus is such an important criterion for diagnosis. In this drawing of an everted tarsus, you can see an upper tarsal zone with long vessels in parallel rows running downwards, a lower zone with short vessels running upwards, a mid-tarsal zone of a connecting polygonal capillary network, and a marginal zone with a capillary network in parallel palisades. And here in the living eye, we see the long vessels, the short vessels, the mid-tarsal capillary network, and the marginal capillary palisades. Behind the typical vascular pattern, we see bright parallel stripes, the columns of the tarsal glands. They may appear hazy, as in this image, or they may appear more distinctly in areas where the blood vessels are empty, as shown here. The visibility of the vascular parallel pattern and the tarsal glands' parallel stripes is the sign of a normal conjunctiva, that is, a sign of its transparency. In contrast, any invisibility of the parallel major vessels and tarsal glands is a sign of disease, as here in this case of subacute conjunctivitis, where vessels and glands are covered by a layer of inflamed capillaries. Or here in this case of chronic atopic conjunctivitis, where neither the parallel vessels nor the parallel bright glands are visible. Note: in the everted lid, beyond the nasal end of the tarsus, is a small section of conjunctiva that actually belongs to the upper orbital part of the conjunctiva. And this occurs also beyond the temporal end of the tarsus. In the lower lid, the tarsus is much shorter, and the vascular pattern is less regular. Orbital conjunctiva. In the orbital part, the conjunctiva has a highly variable aspect because the underlying tissue is loose, very mobile, and the vessels change their position at every movement of the globe. There are folds in many variations, but in a normal conjunctiva, typically all of them run parallel to the globe.
Detailed analysis of tissue changes. In the next chapter, we will describe vascular reactions, papillae, follicles, fibrin and membranaceous layers. Vascular reactions. The picture of vascular reactions involves hyperemia of the vessels with their basic distribution still normal, which, in case of long-lasting irritation, may be combined with vascular neoformation. Hyperemia. In the upper tarsus, in this drawing, we see the capillary buds engorged, while the underlying large vessels are barely changed. Here we see a hyperemic tarsus, with the large vessels only moderately dilated, and a carpet consisting of the capillaries, which emerge from the large vessels and form a fine network of enlarged capillary buds.
Inflammatory vascular reactions. Clinically, we distinguish between 3 types: conjunctival vascular reactions, scleral plexus reactions, conjunctivo-scleral vasal reactions. Vascular reactions in acute conjunctivitis involve all parts of the conjunctiva. They affect the bulbar conjunctiva over the entire surface of the globe. They also affect the lower lid, the orbital conjunctiva, as well as the tarsal conjunctiva, whereby there is a higher density of capillary buds in the narrow band overlying the tarsus. And typically, acute conjunctivitis involves also the upper tarsus, where the entire surface is covered by a carpet of dilated capillary buds, hiding the large tarsal vessels and the glands. By contrast, in scleral plexus reactions, only the area close to the limbus is affected, such as here in a case of corneal inflammation. The deep vessels appear with a bluish tinge. Compare this with the bright red color of the superficial vessels. In this mild case, the limbal capillary architecture is undisturbed. The vessels on the other parts of the eye are not affected, and this is best checked at the vascular architecture of the upper tarsus, where it is easy to determine whether it is normal. To be explicit, a normal tarsal vascular pattern is an important sign of non-conjunctivitis, that is, of inflammations which are confined to the globe.
Conjunctivo-scleral vasoreaction. In this next case, there is a combination of conjunctival and scleral vascular reactions, with strong involvement of the deep epibulbar vessels and severe disturbance of the limbal capillaries, as well as an irritation of the superficial vessels. The involvement of the lids, in contrast, is only moderate. When examining the conjunctiva of the lower lid, we find, beside a zone of artifactitious ischemia, just a slight irritation of the vessels in the orbital and tarsal conjunctiva. In the upper tarsus, there is only a mild reaction. The hyperemic capillaries do not hide the large tarsal vessels. The predominance of hyperemia on the globe indicates a bulbar disease, and the combination, with a reactive involvement of the conjunctiva, points towards an inflammation of the sclera.
Papillae. Papillae form compartments which contain a central core with a capillary bud, a rim of more or less transparent tissue, and are separated by deep furrows. In practice, the papillae are not always distinct, and we must look for other signs. Transparent papillae. Papillae produce irregular reflexes caused by the hundreds of small surface elevations, and the furrows caused by the septa can be found by staining the tear film with fluorescein. The margin of a single papilla, although perhaps invisible at first glance, can be detected by using indirect lateral illumination. And in retrograde indirect illumination, we can recognize also the tiny central capillary buds, which are the main sign for diagnosing papillae. In this case of chronic conjunctivitis, the carpet of the papillae is easy to recognize because it shows not only irregular reflexes, but also hundreds of conspicuous capillary buds separated by clear tissue. The ramifications of the capillary buds have expanded into a net of larger loops, and this is why they appear so distinctly.
Non-transparent papillae. In this next case of chronic conjunctivitis, the papillae, again recognizable by their surface reflexes, are less transparent and thus blur the view onto the underlying larger vessels. The papillae involve also the margin of the tarsus, up to the capillary palisades, and extend even across the edge of the lid margin. The typical pattern of papillary carpets appears most distinctly in a case of exaggerated papillae formation, such as here in a beginning giant papillar conjunctivitis. Here, the tissue of the rim has become opaque, and thus we see the capillary buds in sharp contrast against the whitish neighbourhood, and the rims are delineated by staining the intervals with fluorescein. Follicles. Follicles are accumulations of lymphocytes with the conjunctival tissue. The central core of a follicle is non-vascular and contains homogeneous material. The vessels are on the periphery and surround the follicle like a corona.
This is demonstrated here with a narrow slit light. The core of the follicle appears homogeneous. The vessels are superficial and peripheral. To compare, in the papillae it is the central core which contains vessels, and the homogeneous tissue is at the periphery. Thus, the position of the vessels allows us to distinguish between the papillae, which are developing along pre-formed capillaries, and in which the capillaries are central and deeply buried, and follicles, which are accumulations in between the vessels, and in which the capillaries are peripheral and superficial. Follicles can best develop to their full size in the orbital conjunctiva, as here in the lower lid. Transparent follicles. If they are transparent, follicles can be recognized by their surface reflexes, or with the narrow slit light where their bulging surface can be made out. The homogeneous content of the follicle propagates light and appears in indirect lateral illumination as an extension of the illuminated area into the dark surrounding field. The superficial vascular corona is easily visible in retroillumination against the background of the illuminated core. In the upper lid, we find the fully grown follicles at the lateral ends of the tarsus where the conjunctiva covers orbital tissue. Again with the homogeneous central mass and the surrounding vascular corona.
Confluent follicles. In this case of fibrinous conjunctivitis, the individual follicles are less conspicuous because they are confluent. They do not stand out as a carpet of single globules, but have coalesced into two rows extending along the conjunctival folds. A few single follicles are found only here and here, with their typical homogeneous core and the vascular corona. But if we move to the row of confluent follicles, we find their central mass propagating less light because this central mass is less transparent. There are no vessels inside the homogeneous mass, but there are vessels arriving from the outside to the mass, which are very superficial. Because in the confluent follicles the capillaries do not form a corona, only their superficial position allows the diagnosis of follicular tissue. In the upper lid of the same eye, after removal of a layer of fibrin, we find the large tarsal vessels partially hidden by a pinkish stratum in which we see focal areas of a whitish tinge. Compare this with the vascular pattern of the tarsus in the other eye of the same patient. The whitish focal areas are only slightly prominent, as seen in optical section, and the deep lymphocytic infiltration has formed only these flat elevations, but no really prominent follicles have occurred in the conjunctiva fixed to the tarsus.
Hyperemic follicles. In this case, hyperemia hides details in the conjunctiva, but the reflexes indicate multiple globular elevations. Based on the position in the orbital conjunctiva, one may suspect follicles, but based merely on their aspect, it is difficult to determine whether the protrusions are follicles or papillae. Because in a hyperemic conjunctiva, one can barely attribute the visible vessels to a central core or a peripheral corona. However, in indirect lateral illumination, one can find the bright central masses of follicles and so establish the diagnosis.
Opaque follicles. This is another case in which the follicles are difficult to make out, because they are opaque as well as hyperemic. Nevertheless, when using the narrow slit light, the globular protrusions of the surface can be made out clearly. And when examining in indirect lateral illumination, we can identify the translucency of the central mass and the fine superficial network of the capillaries.
Bulbar nodules. Follicle-like nodules on the bulbar conjunctiva, such as here in a case of sarcoidosis, are easily missed because against the white scleral background, whitish nodules are difficult to see. When we look for a better background, for example, if we ask the patient to gaze laterally, the area in question is moved towards the angle, so by observing it tangentially, scleral reflection is reduced and we obtain a perfect dark background for the whitish nodules. If we examine the nodules of the bulbar conjunctiva in greater detail, we find no corona of capillaries, and the vessels are just running across them.
Fibrinous and membranaceous layers. Such layers are often hidden causes for problems related to the cornea. This is why their diagnosis is important. In this case, the thick membranaceous layers are easy to recognize, especially where partially detached, as here in the lower lid. And in the upper lid, the thick membrane obscures the underlying tarsus completely. No tarsal vessels are visible, and just some trapped ointment droplets appear in indirect lateral illumination. The membranaceous layer can be removed easily. No visible traces are left, and we see just a moderately inflamed conjunctiva. In this second case, the membranaceous layer is more difficult to identify because it is thin and its margins are ill-defined. Only the hazy appearance of the underlying vessels points to a covering layer, as seen here. The layer may be better visible after prolonged exposure because, when drying, it becomes slightly more opaque. The layer is more adherent than in the previous case, and its removal leads to bleeding. Where removed, the underlying vessels appear more distinctly. The margins of the remaining layer can be recognized where the visibility of the vessels decreases. In the lower lid, the membrane is easier to recognize.
Here also, removal of the membrane is difficult and bleeding results. And again, the vessels are better visible when compared with the situation before removal. Still more difficult is the diagnosis of fibrin, in this case without hyperemia. Here, the tarsus is mainly covered by a carpet of inconspicuous fine capillaries, and these are indistinct points of referral. However, closer scrutiny can reveal fibers in the fibrin-containing layer in indirect lateral illumination, and the layer itself can be made out in optical section. By staining with fluorescein, the surface of the tear film can be defined, and this allows the clear distinction between the fibrinous layer and the surface of the fluid. When the layer is wiped with a cotton tip, the underlying tissue with its papillary pattern and the larger vessels appear more distinctly than before the removal of the layer. In this case, the layer is almost transparent, and thus its detection is even more difficult. The underlying vessels appear quite distinctly, and there seems to be no haziness. We have to rely on indirect signs for a diagnosis, such as the immobile air bubbles trapped in the sticky layer here.
Another valuable indirect sign is the presence of an even surface reflex, which indicates the surface to be flat, although based on the papillary pattern of the vessels, we would expect a polyglobular surface. Such a surface actually exists, as shown by the polyglobular reflex, which indeed appears after removal of the covering layer. Compare the two situations again.
This is the end of Biomicroscopy of the Tarsal Conjunctiva, a means for the diagnosis of external diseases. It is part of a series on biomicroscopy of the eye, in which the specific techniques for each part of the globe are explained.